yeah, a little introduction.
So a little bit about me. My name is Deanna Kepka. I'm a health services researcher and an assistant professor here at the University of Utah. I've been here at the University of Utah for about 6 years. I work at Huntsman Cancer Institute, and I'm on faculty in the College of Nursing. I've been working in HPV vaccination research and education for about 10 years. I started working in this field right around the time when the vaccine was approved for girls. That was in 2006. And HPV vaccination is my prevention. I have spent many, many years and countless hours working to integrate this vaccine into our primary care system here in the United States. And I'm hoping to share my passion with you today. I'm also the director of the Intermountain West HPV Vaccination Coalition. So most of my work has been done in the Mountain West states. So I'm excited to be here today. And I look forward to sharing with you some work of my research team and of the Mountain West Coalition with you. So can I move to the slides?
Yeah, here, do you want to take a look at the results real quick, or do you want to look at those later?
I think we'll move to that after we have Mandy's presentation.
Cool, okay. Here. So what you'll do is at the bottom, the share screen.
Okay.
Go ahead and click that, and then select your PowerPoint document.
And then do the beginning.
Perfect, and then. Yeah.
Okay.
All right.
So the title of my webinar today is HPV Vaccination Challenges in Rural and Suburban Settings. So I'm going to focus on one of the most important determinants of who is getting recommended the HPV vaccine and who is receiving the HPV vaccine in the United States, and what factors are related to that recommendation and getting that support for cancer prevention. But before I move into my research and my areas of future research and our discussion on factors related to this disparity, I'd like to introduce to you one of my friends and one of our partners in HPV cancer prevention, Mandy. So I'd like to share a little bit with you about Mandy. She's a writer, a speaker, she's a public relations consultant, she's a cancer thriver, and she is known on social media for her hashtag cloud surfer and champagne lover. One thing I love about her is her posts of champagne glasses toasting all around the world. She's an accredited international travel, lifestyle, health, and wellness writer and features published articles in Thrive Global, Bella Gray's 24 Karat, NC Living, X Magazine, The Huffington Post, Yucatan Times, Live and Invest Overseas, Travel West, and so much more. Her captivating storytelling adds magic to her words, and her passion for writing is contagious as her passion for life and cloud surfing flying. She's an active blogger, and she's just an amazing HPV advocate, and she's here to share her story on why this vaccine is so important and can truly change the lives of so many people. Thanks, Mandy, for joining us.
Thank you, Deanna. Hi, everyone. Obviously, my name's Mandy, and I am joining you from Nashville, Tennessee today. I'm actually traveling, so I'm doing this from a hotel, and I apologize if there's background noise. I'll mute myself when I'm done, so you won't hear any of that. But just want to apologize for that up front, because I do travel a lot, as Deanna said. So as a travel and lifestyle writer, I'm kind of all over the world sometimes, but I am a huge advocate for HPV, and I'm just going to start with my story. And I want to start from August 2003. So this is before, it's pre-HPV vaccine, and I'm sitting in a doctor's office at the University of Utah, and they tell me that, there's a chance that you have a sexually transmitted disease. And I kind of was in shock and awe, and like, how could this be? I'm not sexually active. What's wrong? And reality of it is that's August 2003. By December 2003, I had to make a very big decision in life, and that was to have my uterus and cervix removed. Now, at the time, I did not know that it was HPV, wasn't an STD. It was actually, yeah, you know, like a typical what they were trying to tell me it might be. It was actually HPV that caused me to have cervical cancer. No family history, obviously no vaccine. So I'm sitting, you know, at the age of 22, coming out of surgery saying I'm never going to be able to have children and I have cancer. It fast forwards from there to then I develop ovarian cancer 2 different times. And because of my age, it was, we'll take one, the other one looks fine. And then a year after that, the other one developed cancer. And so it was this repetitive cycle, which I didn't understand. And my health problems started at 16. I had endometriosis. And so I knew, and I'd already been having surgeries every 6 months to combat my endometriosis, but I never knew why I got cancer. And now I do know, and it was from HPV. When I was a young girl, I was sexually abused and went through a few series of years and traumas that actually was where I contracted the HPV. I just did not know, and as slow growing as it is, by the time I figured it out, I had already had cancer. And so I think that what's so important is that the vaccine is so important, but in rural areas where people aren't discussing HPV, we don't know what we don't know. And if we don't have the conversation, we're not helping anybody move forward. And if I could have had the vaccine, my life could have turned out very different. Now, obviously, I was before the vaccine, and how I met Deanna was the fact that my HPV tests became positive again. So it's that worry, that fear that, by the way, you have abnormal pap results, by the way, you have HPV, come back in 6 months. That's 6 months for every single woman that has to go through that. You have abnormal results. I don't care if they're 16 or 52, that 6 months of waiting is some of the most frightening and scary moments of someone's life, waiting, because it's not a blood test that can come back in 10 days. You have to wait 6 months, and then maybe we have to wait another 6 months, and you don't know the entire time if you're going to have cancer and how much it will affect or not affect your life. And that's why I appreciate all of the work that Deanna does with the HPV Coalition and the message that they have, because HPV is, we can prevent cancer. We can literally change the lives of men and women. And it's the most important conversation that we should be having, because this is one cancer that we can completely wipe out. And I don't know if you'll speak to this today, Deanna, but the information that you shared in your TEDx talk with Australia, I mean, combating the mindset that we have surrounding around HPV, it is a discussion, it's a topic, because we shouldn't be afraid of a vaccine that can wipe out a disease. And for one bad post on social media, there's probably millions of lives saved. And so when we breed positive, I believe that we can all surround and come at HPV from a very positive place. And it takes people like Deanna, it takes people like me to share their stories and their work to create change in such a place with stigma. And especially I think in rural areas and where people don't have access to the vaccine or to the conversation. We just have to start talking, and we have to raise our hands and say, let's save lives. This is about saving lives. It's not about, this isn't a vaccine or the stigma around vaccination or no vaccination. It's really about saving lives. So that's a little bit of my story. Deanna, I don't know if you have specific questions, or if we want to open it up to questions.
Let's see, am I unmuted? So can you tell me a little bit about what your relationship was like with your family
Yeah, absolutely. I think that's probably a very important piece.
And I think in a lot of rural communities, there is a lot of challenges with families and talking about this vaccine.
Yeah, absolutely. So I was raised in the Mormon religion, and this stigma of what happened to me, not even related to HPV, was more of like, let's sweep it under the rug, let's not talk about it, let's just hide it from everyone else and then never speak about it again. So not only does that hinder conversation forward in any realm, but it also it's emotional on so many levels. When I figured out that it was HPV that caused the cancer, that's so emotional for me, and still no one wants to talk about it. And they've been very trying to control this conversation of, don't say anything. Let's not talk about it. We can't let people know. We can't let, because what happened to me was done by a family member, which, completely changed my life. Completely changed my life. And I think that when we're talking about small communities and even larger communities, when we're trying not to have the conversation, or we're trying to protect something because we're trying to protect a secret, it's not helping. We have to be able to have the conversation, because now I'm dedicated to speaking out about it, because it's going to help so many other people. These unfortunately, circumstances like mine continue to happen, and we don't know where we will contract HPV. As you know, it's, over 80% of us, is that the number? 80% of us have it. Now, does that always go to cancer? No, and it's unfortunate we can't say who's going to get cancer and who's not going to get cancer. But with my family, they've still been in that place of like, please don't speak out, please don't tell anybody. But they also don't understand. And if we can help one person be able to step forward and receive the vaccine, so if there's an unfortunate circumstance that they contract HPV and develop cancer, we can save their lives. And so it's hard. It's not, I don't think I have an answer on how do we have the conversation of being able to help someone talk, but having different people speak about their situation hopefully inspires a smaller community or rural area to talk about it and step up and I guess do something about it.
Thank you so much for your strength. I think your message is invaluable and so important in the work that we do. Does anyone have any questions? Please type your questions in and Troy can read them out. Or please feel free to share some supportive words. Troy, are you able to get those?
Yeah, I'll keep an eye on the chat, definitely, and let you know. Not seeing anything so far.
Well, thank you so much, Mandy. Really appreciate you taking the time, especially on your long journey from North Carolina to Utah with your, I want to see this car when you get here.
All right. Yes, I'm driving my convertible from Asheville, North Carolina to Salt Lake City. So
that sounds really fun, especially just in time to get here for better weather, hopefully.
We'll go for a ride when I get there. But thank you, Deanna, for all the work that you've done, and thank you everyone for being on the call. And it takes all of us, right? It takes a village to make changes.
So what I'm seeing is many people saying, thank you for sharing your message. Thank you for sharing your story. You're an inspiration. Thanks so much for your strength. It shows great strength. Thanks for sharing your story. Thank you for deepening this message by sharing your story. You're an inspiration. Thank you. So many positive words.
Oh, thank you all.
Thank you so much. Okay, do you want to share the results from what the survey, Troy? Who do we have on the call today?
Sure, I'll pull that up. And there were some issues. I guess we reached our cap of respondents. But yeah, it looks like quite a few in Nevada, some in North Dakota, California.
Interesting mix of people.
Yeah, definitely.
Super interesting. California, Nevada, North Dakota. So a lot of undergraduate students, that's good. We're getting people before they're out as professionals, and this is when we need to reach people. We need to reach people before they become practicing professionals, either in social service agencies or health departments or as doctors or nurses or as parents. Let's get you before your parents, or let's get you while you're eligible for the vaccine. Graduate students, healthcare providers, a few of you, health department, other, great. Sounds like we have a nice mix of people. That's wonderful.
And do you see this question here? What are some new and novel ideas that folks are using to promote higher vaccination rates? I work in a suburban pediatric clinic in Plano, Texas, that mostly serves the medically indigent. What we would love to hear other scripts.
So I think sharing survivor stories is really important for healthcare providers to motivate providers to recommend the vaccine. But I think as we get through our presentation today, we're going to share a lot of the evidence-based methods, like what is the most effective strategies for improving vaccination. And really, a lot of it rests on that strong healthcare provider recommendation and the strong healthcare provider team supporting this vaccine. But we'll get into that a little bit more as we move on in the talk. I look forward to discussing that further. Does that sound okay? All right, so can you still see my slides?
No, I think you'll need to pull them back up again.
Pull them back in?
Yeah.
All right, how about now?
Yep.
Okay, so the goals for today's talk is we're going to present an overview of HPV cancers and vaccination. And then we'll move into what we know about the social, cultural, and instrumental barriers surrounding HPV vaccinations that are relative to rural and suburban settings. And what we mean by social and cultural barriers, they're barriers that affect attitudes, knowledge, interpersonal relationships, perception, recommendations, willingness to accept the vaccine. And then when we talk about instrumental barriers, we're talking about access. Is the vaccine available at the clinic? Can clinics afford to stock the vaccine? Are parents able to get the vaccine due to maybe transportation barriers if they're in a rural setting? Instrumental barriers are more tangible barriers. So we're talking about attitudes and relationships, and then actual tangible barriers. So barriers that relate to costs or direct access or feasibility. And then we're going to discuss evidence-based strategies to improve HPV vaccination that could work in rural and suburban settings, or what we know works across the United States. And then we're going to talk about where we really need future research. Where do we need future research to really close this disparity, to really start equaling out the playing field where location no longer is a determining factor on whether or not you get the HPV vaccine? I hope that sounds all right for everyone. So, how many cancers are caused by vaccine-preventable HPV each year in the United States? 30,000. How many people is this? So I'm in Utah. This is as if each person who filled up our football stadium had an HPV-related cancer that was vaccine preventable. 30,000 cancers, an entire college football stadium of cancers could be prevented if we just increased uptake of this HPV vaccine. That's amazing. And it's more than just cervical, it's more than just female cancers. What else could be prevented? 400,000 cases of genital warts. 400,000 cases. That's 2 times the population of Salt Lake City. 2 times an entire city of people could be prevented from having genital warts. True, genital warts are not going to kill you. But if you ask any teenager if they could prevent themselves from having genital warts for the rest of their lives, they will say yes. If you could ask any mother if she could prevent the transmission of HPV type 6 and 11, which are not cancer causing, they are not oncogenic. Oncogenic means cancer causing. HPV type 6 and 11 are not oncogenic, so if she could prevent the transmission of those 2 types from herself to her child during delivery, which would then cause her child, it could lead to this, recurrent respiratory papillomatosis in her child's throat, which would be recurrent warts in her child's throat, which would be need to be removed by recurrent surgical procedures, she would say yes. The HPV vaccine prevents transmission of those HPV types. It prevents the transmission of 7 oncogenic types and then 2 types that cause 90% of genital warts. Not only that, it prevents precancers. Now, Mandy talked about the anxiety of having that HPV test every 6 months. The HPV vaccine prevents that anxiety. It prevents 90% of the infections that cause precancers and cancers, those oncogenic HPV types. 1 in 10 women will have an abnormal Pap test. This represents cervical dysplasia that is caused by infection with HPV. What does this mean? This is 1.4 million new cases of low grade plus 330,000 cases of high grade cervical dysplasia. Why is this stressful? Why is this a negative occurrence? Well, I think Mandy gave us some clues to this. It causes anxiety. It causes stress about one's sexual health. It causes stress about one's fertility. It causes stress about one's interpersonal relationships, one's sexual relationship with one's partner. It can lead to surgical procedures, medical procedures that can impact your ability to carry a child to term. It can result in hysterectomy for more advanced stages of cervical dysplasia. It can lead to a lot of lost wages, the time you have to take off of work to get these tests, to get the follow-up procedures. We can prevent this with HPV vaccination. So now we need to talk about the HPV vaccine, not as a vaccine for girls, but as a vaccine for all 11 and 12-year-olds. And in the last few years, this is more important than ever. HPV oropharyngeal cancer, if you look at the bottom row, is more common in men than cervical cancer in women. HPV cancers are no longer just female cancers. We have HPV oropharyngeal, more common in men than cervical in women. If you look at HPV 16 and 18, I like to call them our tsunami HPV types. They cause the most amount of HPV-related cancers. And then we have 31, 33, 45, 52, and 58. There are hurricane types. They're the second most damaging HPV types, second most damaging oncogenic HPV types. And then our lighter blue, tropical storm. So the vaccine protects against the tsunami and hurricane types. 90% of the types that cause cervical cancer, and the vast majority of the types that cause oropharyngeal, along with these other cancer types in the anogenital region. This vaccine protects against cancers in men and women, 30,000 cancers each year in the US. So who has HPV? We need to remove the stigma around HPV. And I think Mandy was talking about how stigmatized she has felt, and she is not alone. Because you know what? I have HPV. You have HPV. We have HPV. Nearly all of us have had HPV or will have HPV at some point in our lives. It is so common that 80% of us will have it at some point in our lifetime. Most infections go away on their own. And those that don't go away on their own can cause precancers and cancers. 1 in 4 of us on this call today have active HPV infection. The other trick of it is if we don't know if we have it and it has no signs or symptoms. So any one of us can pass it from one person to another without knowing that we have it. It's when it persists and a person doesn't clear it within 6 months to 2 years, that's when it can lead to precancer and cancer. The other trick of it is in women, we have Pap testing and HPV testing. So we're able to detect it in women and treat it early. But in men, in oropharyngeal cancers, we do not have an FDA-approved HPV test. We are not able to detect it as a precancer in men. We are not able to detect it effectively as an HPV-positive oral infection effectively. We do not have an FDA test for that. That's why now more than ever, it's important to vaccinate boys just as frequently as girls, integrate it into our primary care system. We should be recommending HPV same day, same way as all other vaccines, and at every visit when a child comes into the healthcare system. And this vaccine is so effective, we have dropped it down from 3 doses to 2 for under age 15. The data show this vaccine works, and giving it at a younger age works. The immune system is stronger at a younger age, and as a result, kids can get just 2 doses under age 15 within a 12-month time frame, spaced 6 months apart. And like Mandy mentioned, Australia has a phenomenal vaccination rate. 80% of girls, 73% of boys successfully integrated it into their school immunization program for kids up to age 15, is on the path to become the first country to completely eliminate cervical cancer. Let me say that again. The first country to completely eliminate a cancer due to successful integration of HPV into their immunization program for kids. Where are we with this? We are not quite on that path yet. We can turn these numbers around, but right now we are not quite on that path. We have less than half of our kids, 43%, these are the most recent NIS-Teen DATA 2016, showing that our kids are up to date with the vaccine by ages 17. So this is even older than Australia's data. Australia's data was up through 15. We're at 17, we have 43%. About half of our girls, 38% of our boys. So we see a disparity between girls and boys. So we've got a ways to go to get to the same numbers as Australia. And this blows my mind because this is a safe and effective cancer prevention vaccine. It prevents 9 HPV types, and I think I laid out why preventing these HPV types are so important. It is not a new vaccine. It's been around for more than 10 years. And it has been proven to be just as safe as any other immunizations that we give to our 11 and 12-year-olds. And yet we see this huge disparity. Not only do we have low vaccination rates in our country compared to other nations like Australia, but we see big differences across the US by where you live. If you live in California or in Maine, you're more likely to have been recommended and to receive the vaccine, or Massachusetts, than if you live in Utah or Texas. And you can look at this map and you see the different shades of blue. So the darkest blue regions have vaccination rates of 70% or higher for first dose of the vaccine, where the lightest regions have less than half of the kids. So this is a disparity. This is where we see big disparities by where you live, likelihood of having received the vaccine. Then, so those in certain locations have a much higher likelihood of having received the vaccine than those in other locations. It's a geographic related disparity. And then when we look at other disparities around HPV-related cancers, we see a little bit of a flip. So in the South, we see lower rates of HPV vaccination rates. We don't see a lot of dark blue in the southern region of the US. We do know a lot of those southern states are rural, like South Carolina and New Orleans. They have very light blue HPV vaccination coverage. But then when we look at HPV-related cancers in the South, we see a lot of this darker orange to red, which means that they have higher incidence of HPV-related cancers in the South. So they're not receiving the protection because their vaccination rates are lower and their HPV cancer incidence is higher. It doesn't mean the whole country shouldn't be trying to strive to meet that HPV Healthy People 2020 goal of 80% vaccination coverage, 2 or 3 dose completion. But I'm still showing an additional disparity that we're going to see over time by these regions of the country with higher HPV cancer incidence and lower HPV vaccination. So health officials are seeing this disparity, and there's been news around this. We're seeing this rural-urban gap widening. And unlike in the past where we've seen urban regions, lower-income urban regions having larger challenges with access to preventive services, we're seeing the flip with the HPV vaccine. And that's why health officials are puzzled. And I'm going to walk you through this. So these are those NIS-Teen data again. They're the most recently available data. So let's look at the first column, first dose. This means kids that by the age of 17 who've received the first dose of the HPV vaccine. So the average for first dose receipt of the vaccine is 65%. That means 65% of the kids by age 17 in the US among boys and girls have received 1 dose. If we look at urban kids, it's almost 71% have received 1 dose. But then we look at suburban, it drops down by 8 percentage points, 63%. And then rural, 56%. Oh wait, so, and then that's for females. And then when we look at males, it's 56 for the US average. And then for males, for first dose, for urban it's 61, for suburban it's 54, and rural it's 44. So we're seeing this huge disparity. On every single measure, you're seeing a reduction. So let's do this one more time. Females, urban, 70%. Suburban, 63%. Rural, 56%. Males, urban, 61% for first dose. Suburban, 54%. Rural, 45%. Now let's look at third dose. For females, we're seeing urban, 48%. Suburban, 42%. So it's the same pattern. Rural, 34%. So there's a huge gap between urban and rural, from 48% to 34%. But that suburban is right in the middle too. There's a gap for suburban. And then we look at males, again, it's the same pattern. 35% for urban for 3 doses, 30%. So this is when 3 doses were recommended, 30% for suburban, and then only 23% for rural. Wow, that is such a huge disparity. And it's a trend that is happening across the whole country. So I'm going to talk about some rural barriers to vaccination. So these are some general barriers that we know to HPV vaccination that are happening across the whole United States. Major barrier. A lot of people are just not associating, even though this vaccine's been around for 10 years, HPV is related to 30,000 cancers each year in the US. People are just not making that association. They're not making the association of the relationship between HPV and male and female cancers. Across the whole US, people are waiting to vaccinate until older ages. They're thinking it's not an appropriate vaccine for younger ages. They're thinking, oh, it's an STI, we can wait until my kid's older. They're not thinking it's for 11 and 12-year-olds. There's been a trend, there's been an overly feminized attitude about this vaccine for that it's for girls and not boys, because maybe in part because it was recommended in 2006 for girls and in 2011 for boys, maybe in part because it was really promoted as a cervical cancer vaccine, but then there's been this delay of uptake for boys. A lot of times adolescents at these ages, 11, 12, 13, 14, they're healthier. So they're not going to the primary care providers often, don't have as much opportunity to get the vaccine. It hasn't been framed as a cancer prevention vaccine. All the stigma around sexually transmitted infections and talking about it at this age where kids are going through puberty has just caused so many problems that this vaccine has not been successfully integrated into primary care for this age. Now let's look at rural challenges. Strong provider recommendation. We know this is the #1 reason why a kid gets this vaccine. And we know in rural regions, it's even less likely that a provider is going to make this strong recommendation. There's just data that shows that providers are even more hesitant to make this recommendation in rural regions. We know that there's healthcare system challenges for why the HPV vaccine is not being strongly recommended, or systems aren't being developed to integrate reminder systems. It's even more challenging in rural environments because healthcare systems have fewer financial resources. They may have fewer providers. They may have electronic health record systems that are not as fancy or sophisticated. So in a rural region, it's even more difficult. Those same challenges that are present across the whole US are even more problematic and have a greater impact and less likelihood of kids getting the HPV vaccine. What else is going on? There's multiple doses for this vaccine. So this can be a problem for kids all over the place because kids are busy. 11 and 12, 13, 14-year-old kids are busy. Parents are busy. But now if you factor the multiple doses in a rural environment, some parents are driving 1.5 hours, 2 hours to get their kids to the doctor. If they have to go back for 2 and 3 doses, that's going to be an extra hindrance. It's going to be another barrier that's going to prevent vaccine completion. Costs. This vaccine needs to be stored in a refrigeration. It needs to be refrigerated. This can be expensive for a rural practice if it's a small practice and if there's a low demand for this vaccine. If patients are not accepting this vaccine, if it's not being integrated into vaccine delivery, it can be expensive to stock this vaccine if the vaccine is expiring and it's not being used. So there's higher costs for cold storage if the vaccine is not being used for rural practices. And when you have few patient populations, so in some rural clinics, they may only have 50 age-eligible kids in a whole year for this vaccine. So this could be really difficult, or they may only have 100 kids compared to an urban practice that has thousands of kids. These are huge challenges. And then the availability of the vaccine. I've talked to a number of small practices in Wyoming and Montana where really small practices, like maybe only 1 primary care provider or 2 primary care providers at the practice, and they cannot afford to stock the HPV vaccine. They can't afford to stock any adolescent immunizations. So what they do is they recommend the child to go to the health department to receive their immunizations. Well, this is an extra step. So this means the parent needs to go to the primary care provider for the well-child visit, and then needs to go to the health department to get their immunizations. So it's an extra step. The parent is more likely not to do it. One more step. It's another trip that they have to make. And then the next challenge is tracking. It's making sure that the data are reported back to the primary care provider. So this is where I see the additional challenges that rural practices have on top of the standard challenges, the standard barriers to HPV vaccinations. And I'm getting this information from conversations with rural doctors, from literature reviews that I've done, and from some of my own research. So I'd like to stop and just for a few moments and see if anyone has any questions or any comments I'm just going to take a little drink of my coffee about some of these points before I move on to my next topics.
Yeah, Deanna, there's some comments here from
Okay,
June.
trying to
Hunter.
see them. Okay, yeah.
This is great information. We have to do more to change the conversation. And Christy Brown shared, providers need to recommend this. This is very important. There needs to be a concerted effort made in rural communities regarding getting HPV vaccinations to the kids.
Yeah, thank you. Definitely, especially, yeah, we need this protection. And a lot of times we see disparities in cervical cancer in rural communities because of access to Pap testing. So that's why we need the protection even more. Okay. Anything else?
Not right now, no.
Okay, I want to move on. So now I'm going to talk a little bit about my research in Utah. So the thing about Utah is we have some large metropolitan regions. So we call the Wasatch Front, the Salt Lake City, Provo area. And then we also have St. George, which is border of Nevada, not far from Las Vegas. So those in Nevada are familiar probably with St. George. But then we have many rural towns, and we have regions which are considered frontier. And so that means very, even smaller than rural. So few people, just a few people per square mile. So that allows us to measure differences between urban and rural. And so what my team was able to do is we looked at missed opportunities for HPV vaccination using registry data. So we got a hold of our immunization information system. So most states have vaccine registry data. But the challenge with it is for researchers to work with health departments to get access to these data. It's really difficult, but we were really successful. We have a phenomenal health department, and we built a really great partnership. So we got access to data on 55,000 girls over a 5-year time period. And these data allowed us to see real-time visits when girls went in and got immunizations, from 80% of the visits that happened in Utah over this time period. So we're able to see what happened when kids came in for immunization visits. Did they get the HPV vaccine or not when they got another adolescent visit? And this paper was published a few years ago in Papillomavirus Research. You see the citation below if you want to look it up and learn more about it. So what we saw is, so this data is more sophisticated than the NIS-Teen data, which I was just reporting to you, because that data is survey-based, and then they pull medical records, but they're just looking at overall vaccination rates. Well, we're looking at individual visits to a provider office and what happens in those individual visits. So these are more exact data because we're looking at every single interaction when a vaccine is delivered. And we saw it when we looked at all of those 55,000 interactions for those women and those girls. 44% of the time a girl got another vaccine and not the HPV vaccine over a 5-year time frame. So that means there's 44% of the time we could have improved access to cancer prevention. And then there was another 40% of the visits we saw a missed opportunity where there was an opportunity to get dose 2 and 3 and the patient didn't get that vaccine. So there was a lot of missed opportunities happening in Utah over that 5-year time frame. And then we dug a little deeper and tried to tease apart what was going on a little bit closer. And we saw that 2 out of 3 preteens, that means 11 and 12-year-olds, had a missed opportunity. So our younger kids are definitely most likely to go in and get one of those other immunizations, which is Tdap, meningococcal or Menactra, or flu, and not HPV. And this is the age when you really should be getting the vaccine. You'll get the most protection at this younger age. And so 2 out of 3 of our younger teens are getting a missed opportunity compared to 1 out of 3 of our older teens. And then we found in Utah, whites are more likely to have a missed opportunity compared to Hispanics. And that's where we're seeing so many differences with this vaccine compared to other health issues. We're seeing this disparity. It's just a flip. It's like a reverse disparity where urban kids are more likely to get the vaccine. In Utah, Latinos are more likely to get the vaccine. And then now for the hot topic of today, we see urban kids are less likely to get the vaccine. So rural kids had a higher level of missed opportunity, which means they are more likely to see their doctor and get Tdap, meningococcal, or flu. 42% of the time they went in to see their doctor and got one of those other vaccines and not HPV over 5 years. Some limitations in this study is we weren't able to look at visits when they went in and didn't get a vaccine. I would have liked to look at like when they got a physical or when they went in for another visit like strep throat or ear infection, because really the vaccine should be offered at every single visit. And sometimes there's mistakes in data entry in these type of data, so we had to do a lot of cleaning. But the strengths are, these are data for the whole state. They're very complete with huge participation and a very long time interval. So here's where I think we need more research. We need to look at more provider and healthcare system level factors, especially in suburban barriers. This is where it's really tricky because it's like middle ground. It's easier to tease out the urban and rural because they have, it's clearer with looking at different zip codes, looking at more distinctive factors based on population and the way healthcare systems are set up. What's going on in these suburban settings? What's going on with vaccine hesitancy? What is going on with attitudes? Is it really a stronger rates of just concern around vaccination overall that's impacting it, or is it problems with HPV vaccination specifically? Is it at the provider level or the parent level? Is it factors around bundling practices, or is it perceptions by the doctors that these kids aren't risk for HPV-related cancers, so we don't need to recommend this vaccine in suburban practices? So I think there's so many issues that need to be teased apart in that lower level of HPV vaccination that's taking place in suburban settings across the US. So I'm going to move into talking a little bit about some evidence-based strategies that we know improve HPV vaccination. So we need to be educated, and this is some of the work that our coalition's been doing. We need to learn about making this a public health priority. We need to become Australia. We need to be right up there with one of the countries that's on the path to eliminating this cancer. We need to make sure that our providers are on board with this. This is not an optional vaccine. You don't have the option to talk against this vaccine. This is part of our public health platform in the United States, supported by the CDC, the ACS, the National Cancer Institute. We need to share the benefits with parents and patients. It needs to be bundled. When your child comes in for a visit, your physician or primary care provider or nurse should be saying your child needs 3 vaccines today: Tdap, HPV, and meningococcal. Today, your child should have 3 vaccines that are designed to protect him and her from meningitis, cancers caused by HPV, tetanus, diphtheria, and pertussis. Bam, that is it. It should be routine procedures to reduce missed opportunities. Here are some evidence-based interventions that work. Standing orders. What do standing orders mean? They mean all medical staff who are eligible to deliver vaccines should be able to deliver vaccines to age-eligible parents. You don't need to wait for the doctor to approve it. They should just be able to do it once a child is in there and is willing to do it. You have the parent's approval, bam, you do it. Provider prompts. Providers should be reminded that a child is eligible to do it through EHR systems, electronic health record systems, and they should be giving that strong and bundled recommendation that I just demonstrated for you. Providers need to assume parents are getting it. Don't ask a parent, just tell them. Tell them they're getting it. Be confident, don't present it as optional. Use parent-patient reminder and recall systems. This could be really important in rural settings, especially if you have to commute pretty far away to get to your provider. Those postcard reminders, texts, emails, phone calls could be really helpful for reminding parents to get into their provider office, or maybe to make that appointment when they're making another trip into town for another reason. And to really encourage planned, use, study, act cycles. So what these cycles are quality improvement processes where if you want healthcare teams to improve, they need to know how they're doing. So they need to be interfacing with data, but not on a big scale. It's not going to help them to know what their vaccination rate is for an entire year. It's going to help them to know what it is for today and tomorrow and this week. So they could set tiny goals to try and improve, and they can make small changes and see how that in fact impacts their vaccination rate. It's almost like each day is a tiny experiment. And if they change their language a little bit, if they do things a little bit different, if they work together as a team in a slightly different way, how does that impact their rates? And that helps motivate them. Looking at data, looking at ways where numbers go up or down, can help them make slight adjustments to then improve or adjust from a decline to make a change and try again. All of these processes work. We are working with American Academy of Pediatrics here in Utah. Right now we're doing a quality improvement project with small practices in Utah, Wyoming, and Alaska. We use HPV cancer survivor stories. Mandy is one of our advocates to share stories with pediatricians who are working in small practices all over this region with low HPV vaccination rates to help motivate them to make that strong recommendation. So pediatricians and their healthcare teams often never seen HPV cancer. HPV cancers affect people in their 20s, 30s, 40s, 50s, sometimes 60s. So we want them to make this cancer real. We want them to feel how painful it can be on someone's life. If they feel that, they will be inspired and motivated to know that they are doing good when that child gets that vaccine. We also include webinar-based provider coaching strategies on those plan, do, study, act cycles. And we use webinar-based strategies on a monthly basis so people can participate from anywhere in the world. They can participate from rural Alaska, rural Montana, rural North Dakota. So, and it helps have interaction and get feedback on their vaccination strategies that are working, help them look at their data, map their data out. And in the past, we did the same study, the same quality improvement project with Montana, Nevada, Utah, and Wyoming, and we had improvements in vaccination rates. Not huge, but small ones. But every vaccinated child makes a difference. That's one child who's going to not be facing HPV-related disease. Some future areas of research that I think are needed is we need to look at the effectiveness of targeted provider and healthcare team training activities for rural and suburban settings. What do we need to do differently in these settings? What are the characteristics of these rural and suburban regions that are really relating to lower rates of vaccination? And how does that relate to where we should be targeting our interventions and how we should be designing our interventions? Aside from that strong provider recommendation, do we need other messages for parents in rural and suburban settings? Do we need to look at this, come at it from a slightly different angle to be more impactful and to address parent concerns? How can we get rural and suburban practices to own and prioritize HPV vaccination? I think our HPV advocate program is one way of doing that. I think stories like Mandy's really help. How can we make this more normative? How can we get them to buy into how important it is to prevent experiences like Mandy's had? How can we improve access to HPV vaccine in rural clinics? How can we subsidize the costs for storing the vaccine in rural clinics? You know, is it fair that a rural clinic needs to pay the same as a wealthier, more urban clinic to store and stock that vaccine? I don't know, because that's limiting the access of that vaccine to rural kids. And how do we best monitor and celebrate improvements for HPV vaccination rates in small practices? So rural practices may not have these fancy electronic health record systems. They may not even have EHR systems. So what are some ways that we can give them feedback on their data and help them celebrate their achievements? So what questions do you have about location and HPV vaccination? Let's see, we have a couple minutes. Feel free to.
Yeah, we do have some questions in the chat so far, and one comment. So Jay Anderson says, I'm in Elko, Nevada, and we're hosting a teen health fair May 22nd. We're having a vaccination clinic at the health fair to include HPV. I can't thank you enough for this presentation. It will help us as we move forward with promoting the event.
Great, thank you.
Question here, is it reasonable for men older than 26 to get the vaccine?
So for that, it should be a discussion between yourself and your provider. That is completely up to you and your provider. The only issue with that, it could be reasonable, definitely, is it is not likely that insurance will cover it unless you're of a very high risk population.
Are family practitioners / general practitioners included in the outreach and improvement efforts? Rural areas may not have pediatricians.
Definitely. So, yes. For AAP, they focus on pediatricians, but for my work, I focus on primary care providers. So I'm working on a couple big intervention grants, and if they get funded, all of my partners are family practitioners and general practitioners.
I've been reading a lot of articles and blogs on the internet stating that the HPV vaccine will cause horrible side effects, although not sure how true these statements are. Do you have any studies or evidence comparing the data between vaccinated people who have had issues directly correlated to the vaccination versus issues caused by HPV in unvaccinated people that could be prevented if they received the full vaccination?
So the CDC has done a phenomenal job of reporting VAERS, which is the vaccine adverse side effects, VAERS, and there is no reason to believe that HPV has any more associated adverse side effects than any other vaccine that is given at this age. So the associations we don't see, but it doesn't mean it's impossible. But at this point, there are no known serious side effect associations noted other than pain at injection site and the risk of fainting following vaccination. So because of the risk of fainting, it's recommended that kids and young adults sit down or lay down after they're vaccinated. But the CDC has done an excellent job tracking vaccination risk, and they track association with serious side effects. And at this point, there isn't higher risk with known serious side effects.
Is there any benefit to getting the vaccine after you've already been diagnosed?
I think that's another conversation between yourself and your provider. I think if you're within the age recommendations for the vaccine, which is up through 26, it protects against 9 types. So the idea around the age 26 is unlikely that you've been exposed to all 9 types. So you may still benefit from protection in the vaccine against one of those types or most of those types.
Okay.
So there's still benefit up through age 26 based on epidemiological estimates.
Any tips for dealing with anti-vaxxers?
I think it's anti-vaxxers. I'm still learning. I don't know, other than I think if people have a difficult story of someone who they believe has been harmed by a vaccine, I think to show compassion, because when a child has ever been harmed, we need to show compassion for any child's pain or illness or disease. And I think what I like to do is just cite the data that we do know, the sources that CDC knows, and I cite associations. But when we look at causes, we can never say that something does not cause something. We can just say the data show that it's unlikely. That's what I try and do. That's the best I can do.
Okay, just hit
kind of like hypothesis testing, right?
Yeah, I just want to make sure that we address these few last questions.
Yeah.
If you have to sign off, feel free. Thank you so much for joining us today. This was a really great talk and great discussion.
But please share my slides with everyone, because I have a link to my TED Talk. I have a link to our coalition if anyone wants to join our coalition, which we have monthly webinars. We're also hosting a meeting in June here at Huntsman Cancer Institute, and anyone's welcome to come. It's a national HPV vaccination meeting that's going to be co-hosted with NCI and the CDC and all the cancer centers who are working in HPV vaccination.
Okay. And just a second,
please share my slides.
Yeah, I'll send out the link for the slides. Can you provide some talking points when parents say, my child is with me all the time, they aren't having sex, or I've heard the vaccine can affect fertility.
So I think for the not having sex, I say this is a prevention vaccine. And it's given at 11 and 12 because your immune system is best able to respond and give protection against the HPV types in the vaccine. It's supposed to be given before sexual activity is begun. So I stress that it's not supposed to be given when sex begins. It's not supposed to be given after sex has been initiated. It's supposed to be given early on, many years before sexual initiation, and that's when the body best responds to the HPV types in the vaccine. And that's why evidence has shown us that it's so effective that we only need 2 doses under age 15. And then the fertility, I would say data have not shown that it is not associated with lower rates of fertility. In fact, abnormal pap tests are related to problems with fertility. The data show the opposite, that abnormal pap tests are related to risks of infertility and extreme or higher rates of cervical dysplasia in extreme cases can be even related to hysterectomy. So in fact, the opposite is true. That's what I would say.
Have you heard of any programs where HPV vaccination is administered by a nurse in a school-based program? Seems like that would reduce barriers of the vaccine expiration and travel.
Yeah, I know of programs in Utah, in our small towns here, they kind of receive a blanket permission from parents to administer it, but I do know it's a little slippery slope, and they do need to receive permission from the parents to do it. So what they do is they say, we're going to give your kids XYZ vaccines, and they just have HPV as one of them, and they've been successful in doing it. But when I interviewed this nurse and I really wanted to do a press story on it, I wanted to, commend her as a hero. She didn't want to do it when I wanted to show her off in the media. So I think it's a slippery slope.
And
She was a local hero, but she wanted to stay quiet about it.
Yeah, maybe some stigma.
Yeah, I think it's possible, but you kind of have to. In my culture here, it's a quiet, unsung heroes that'll do it.
What's the current thinking about the possibility that vaccinating against high incidence HPV types will in the long run result in other types becoming dominant as the cause of cancer?
There's no reason to believe in that. If you look at data in Australia, if you look at the fact that the top epidemiologists in the world who study HPV types, this is their job, do not support that as a feasible hypothesis. When we're looking at the incidence of cervical dysplasia related to vaccination and a declining, there's no reason to believe that. But who knows what could happen in 50 years?
Yeah.
I think it's unlikely.
Texas was one of the states that had the lowest vaccination rate, but it still was low for HPV. Why is that?
Good question. It was low for HPV-related cancers. I think if you look, well, for one thing, you can't see the relationship there because the vaccine was just improved in 2006 for girls, and it takes 20 to 30 years to develop cervical cancer. So we're not going to see a relationship to cervical cancer yet. So when I presented those 2 slides, my argument was, we know we're looking at 50 years from now. What I said, good question, I meant, I don't know why Texas is low for HPV-related cancers. I would think certain subpopulations do have higher HPV-related cancers incident, but we're not seeing a relationship right now between incidence of HPV-related cancers in states and their vaccination rates. We won't see that for another 20 years. What we're seeing now is just relationship between HPV vaccination and declines in HPV infection at the population level. So we're able to see that now.
How do they join the coalition?
Oh yeah, so you can email me. deanna.kepka@utah.edu, and I'm in the slides at the end. And just email me and you can join our coalition. You'll be on our listserv and you'll get all our monthly updates in our newsletter, and you can join our monthly meetings. They're all webinar based, and we have amazing speakers from all over the country. And we try to invite, next month we're going to have an oropharyngeal cancer survivor from Florida, a male, a guy. So we try and get speakers who have different experiences to share their stories too.
Okay. On your slide, you wrote the vaccine should be completed by age 13. Is there a reason for that? I know it can start at age 11, but is there a reason it's best if it's completed by age 13?
So the recommended ages, I mean, that's the ideal recommendation guidelines. Those are the CDC recommended practices. It doesn't mean better late than never. So better late than never. Like if you get one dose at age 11, you can complete the series and get your second dose at age 18. You won't even need a third dose. Better late than never. But the younger, the better. The guidelines are 2 doses under age 15 within 12 months. Starting at 11 and 12 are ideal because it's really supposed to be integrated with the Tdap and Menactra vaccines. Some practices are starting as early as 9 and 10 because they think parents are more willing to accept it at that age. So they give 1 dose at 9 or 10, and then they give the second dose at 11 when the kid comes back for Tdap or Menactra, and bam, they're done. So there's a lot of different ways to do it, but the younger the better. So that's why it's best by 13.
All right, I think that was the last question here. Thank you so much, Deanna, and thank you, Mandy, for sharing your story. This was just fantastic. Thank you.
Thank you. Have a happy weekend.
You too. Bye-bye.
Bye.